Michael Detsky, that's how I know him, 2007?
Yeah.
Yeah. And then you did your medicine here,
Yeah.
and your cardiology here,
Yeah.
and then you went away to,
No, I think
did a PhD in Glenappy, right?
Yeah.
With, do you know him?
Yeah, Jeff Anderson.
Jeff Anderson, okay. And he's a very famous scientist. He has like lots of awards, and he's smart.
Thank you. Well, I mean, thank you for that introduction. I don't think it's accurate, but
It wasn't accurate?
I don't think it's very accurate, especially the last part. But I'll do what I can to try and not disappoint. So I'm going to thank you for this invitation. I actually asked George to speak mostly for selfish reasons because this is an area of research that is outside of my scope of expertise. Like my PhD, a lot of my clinical and research interest focuses on heart disease in patients with cancer. This is a very different area, but yeah, so it's a very different area where I've trained and most of my research has been, but it's sort of influenced by a lot of questions that patients have asked me. And as you're going to see, there's some methodological challenges associated with it that I was hoping you could provide me some input with. So, notable conflicts of interest to this study, educated events for the PHEMIS trial, which was my AstraZeneca, doesn't make any AF drugs, and I consult Amgen on the cardiovascular risk with one of their drugs. They don't make any AF medications either. But apart from financial conflicts of interest, I think, you know, scientists, in particular clinician scientists, we all have our own biases as we approach research. And I have to reflect on what some of my own biases are in approaching this work. And in general, I think my sources of biases come from the fact that despite being a cardiologist, I actually really don't like prescribing medications for primary prevention of disease. So it's a different, for me, it's a very different calculus if someone already has cardiovascular disease that's established and I'm giving them medications to prevent it. But for someone who is otherwise well and who may or may not develop a cardiovascular event, I philosophically tend to believe that the burden of proof should be higher. And, you know, this bias may have influenced how I approach this. In general, I also like to, if I prescribe a medication for primary prevention, I tend to prefer medications that can protect multiple aspects of someone's health. So, for example, I'm much more likely to prescribe an antihypertensive because it would reduce atherothrombotic events, stroke, heart failure, kidney disease, than prescribe a blood thinner, which would be the only thrombotic event. But then on the flip side, when thinking about atrial treatment for atrial fibrillation, you're balancing stroke and bleeding risks. And I would much rather myself or my patient avoid a stroke than a bleeding event because strokes can have, if they don't take your life away, are going to leave you with much more disability than a bleeding event. So I think these biases may all factor into how I chose to approach the study. Okay, so what are my objectives here? So I'm going to take you through at least my understanding of the data that influence some of our recommendations to prescribe people with blood thinners to protect them from stroke in the setting of atrial fibrillation. I'm going to present data from a study that I'm presently working on to submit for publication soon. And most importantly, I was hoping for you to tell me what you thought about the study design. Is there anything that can be done to improve it? Okay, so for the non-clinicians in the room, atrial fibrillation is the most common quote-unquote serious heart arrhythmia. So in our hearts all have a natural pacemaker that regulates how fast it beats and keeps it beating in a regular manner. In the setting of atrial fibrillation, the heart's natural pacemaker stops working. The heart beats faster and in an irregular way. The likelihood for this increase is this is very common, but the likelihood increases substantially as people get older. So once people over the age of 65, men have a 3% prevalence. And once people get over the age of 80, almost 10% of people have atrial fibrillation. Now, it has several important health consequences, but the most important and most dreaded consequence of atrial fibrillation is that it increases the risk of stroke. It increases the risk of stroke substantially, with relative risks of like 3 or 4. And it tends to interact with age towards being one of the most responsible, one of the biggest reasons why elderly individuals develop stroke overall. Now, we've known this for a long time, and this is really, and because of this, the focus of atrial fibrillation management increasingly has been on what can we do to protect these individuals from stroke. Now, this is a relatively sophisticated crowd, so I don't have to go through differences between absolute and relative risk, but in general, treatment decisions for atrial fibrillation are prescribing blood thinners for patients in whom the absolute risk of stroke is thought to be high enough to justify the use of a blood thinner. And in trying to estimate people's absolute risk of stroke, a few different schema have been researched, but what has really won out and stood the test of time has been the CHADS-based method trying to predict the risk of stroke. So the CHADS model is an acronym, so it takes factors such as congestive heart failure, hypertension, being over the age of 75 years, diabetes, and the presence of prior stroke. You get 1 point for each of these factors, 2 points if you have prior stroke, and then the greater the number of, the greater the number of points, the greater the risk of stroke. Now, one of the issues with the initial CHADS score was that even patients that had a score of 0 still had a 2% annual stroke risk. It was felt not to discriminate well enough in patients at the low risk category. So the investigators refined this further to developing something called the CHADS-VASC score. So it additionally added vascular disease. It added an extra point for patients who were over the ages between 65 and 75 years, and added an extra point for female sex. Now, the point associated with female sex really hasn't stood the test of time, and most practitioners don't take that into account. But basically, the CHADS-VASC score, or the CHADS score, is essentially how people around the world decide whether to give someone with atrial fibrillation a blood thinner or not. So what do we do in Canada? So in Canada, basically, any person that has atrial fibrillation over the age of 65 years, our Canadian guidelines strongly advocate that these patients should be treated with a blood thinner. If they have any of the other CHADS risk factors, they also should get a blood thinner. Otherwise, either get antiplatelet therapy or nothing. So I've started practicing in an outpatient setting only for the past 2 years, and I've tried to apply these guidelines diligently to my patients. And my patients ask me some pretty simple, straightforward questions, but I found that I really couldn't give them a good answer for. Some of them being, what is my risk of stroke if I choose not to take this blood thinner? Particularly the healthier younger ones. What is my risk of stroke if I follow your recommendation, I take a blood thinner? And I think my favorite question that people have asked me is, are you telling me that I have to take a blood thinner every day for the rest of my life just because I turned 65 years last year? In fact, one of my patients who I've been following for atrial fibrillation, who have been mentally preparing for the fact I'm going to be starting him for a blood thinner once he turns 65, essentially sarcastically describes it as a 65th birthday gift that he doesn't want. I'm going to force him to take. So this has kind of prompted me to think about, well, why are we doing this? And I think part of my skepticism comes from the fact that we here in Canada, our guidelines for anticoagulating patients with atrial fibrillation are more stringent and more aggressive than where they are anywhere else in the world. So if you live in the United States, the guidelines say that you only start anticoagulation with a CHADS-VASC score of 2 in men or 3 in women or higher. Now, in Europe and in the UK, with the NICE guidelines, they have the strong recommendations that mirrors the American recommendations, but they also suggest that you should consider anticoagulation for patients with a CHADS-VASC of 1, which patients who are between 65 and 74 would fall into if they're otherwise healthy. Now, the CHEST guidelines, which kind of started off as a group that was led by the American College of Chest Physicians, are more similar to the Canadian guidelines, in which they suggest anticoagulation for patients with a CHADS-VASC of 1 if they're a man, or 2 if they're women, which is where someone who is age 65 to 74 years and is otherwise healthy would be. So basically, depending on where you lived around the world and which guidelines you would follow, there are different recommendations to what you would do with if you saw the hypothetical case of a 66-year-old marathon runner who happened to get atrial fibrillation because he's a highly trained athlete, but otherwise has nothing else wrong with them. So if you lived in Canada, you follow the CHEST guidelines, you're told to anticoagulate these patients. If you lived in the US, you're told not to anticoagulate them. In Europe and in the UK, you're told you should consider anticoagulate. And then the statement of the guidelines doesn't really distinguish between men and women, so you may be more likely to anticoagulate a woman in that age range versus men. So where does this discrepancy really come from? So with the American guidelines, it's pretty simple. Their recommendations were only based on RCT data. And basically, all the RCT data that tells us about anticoagulating patients with atrial fibrillation have involved patients that have had higher stroke risk. And these have tended to be patients that have had CHADS-VASC scores of 2 or higher, and so 2 in men and 3 in women, which is why the American guidelines were pretty straightforward. Essentially, that's the only group that they recommend anticoagulation for. Now, the reason why the other guidelines are different is because they have sort of tended to extrapolate from the guidelines, and the thinking is, well, we know that these medications help patients that are at higher risk. And we know patients who haven't gotten into these RCTs, though, are still at a reasonable risk of stroke. And perhaps, we should consider anticoagulating patients if their risk of stroke was meaningful but wasn't high enough to get into the trial. And the thinking is influenced by data such as these. So this paper is comes from a Markov decision model, analytic model, that has tried to, look at the benefits and the risks of starting anticoagulation relative to someone's estimated baseline risk of stroke.
Mark was here about a month ago.
Oh, he was?
Giving these, standing exactly where you are.
Oh, really? Did he speak on this or something?
He spoke on hepatitis C.
Okay.
But same modeling approach.
Okay.
It's the same graph.
Yeah. Well, so this analytic model is actually cited by a lot of the guidelines, and I think sort of influenced how a lot of the guideline thinkers have approached this. But essentially, they modeled the benefit versus the risk of aspirin, warfarin, which has sort of been the old school blood thinner, and newer blood thinners, the direct oral anticoagulants. So for the non-clinicians in the room, warfarin, although it works well as a blood thinner, it's quite undesirable because it's very unpredictable in terms of how it acts. So as a clinician, when you prescribe warfarin, you don't know how it's going to affect your patient, so you just make a guess. You guess at the dose. You give the patient the dose. You send them home for 3 or 4 days. They come back later. You check their blood, and you see if their blood is not thin enough, you give them more blood thinner. If their blood is too thin, then you scale back on the dose. You check their blood again 3 or 4 days later, and you essentially repeat that. And because of that, the medication is inconvenient. It's in effect, patients spend a lot of time when their blood's not thin enough, but they also spend a lot of times when the blood is too thin and are at risk for bleeding. The newer blood thinners are safer, are much more predictable in terms of how they work, and are potentially more effective depending on which data you look at, which is why they're desirable.
Only because we don't measure.
Well, arguably we don't need to measure for most people, but I guess that's a discussion for another day. But essentially, taking those assumptions into mind, the decision analytic model argues that if you were to treat someone with warfarin, the risk-benefit balance sort of starts tipping at around an annual stroke risk of about 1.7% per year. And that said, if the risk of stroke was higher, then patients would benefit from warfarin. With the newer blood thinners, the DOAC, the risk-benefit balance seems to tip at around 0.9% per year. And I think this is sort of the thinking that has led the Canadian guidelines to be so aggressive, the fact that the new blood thinners have come around, and also the fact that through looking at some of the data, they believe that the annual risk of stroke in someone who is 65 and is otherwise completely healthy is going to be around the 1.5% mark. But I think if we're going to extrapolate from RCTs, I think it becomes sort of very important to understand what the actual stroke risk in people is. And if we step back to the CHAD score, and this is sort of where the whole AFib enterprise is based on, it's actually shocking the quality of the data that this is all based on. So if you look at the initial CHAD score, which we've been using for almost 30 years now, the whole thing was defined based on 94 strokes. And we're using this to treat everyone around the world with AFib. What's even more appalling is the CHAD VAP score was based on 25 events. And this is a predictive model that has 9 predictor variables. So kind of do the math, right? And I can't believe that this got published, but this is sort of what we've been basing things on. The other caveat is that the stroke rates that are reported are not actual stroke rates because we were worried about stroke risk and practitioners would have treated these patients with aspirin at the time. And because of that, all of these patients were not following the natural history of the disease, and they essentially adjusted the observed stroke rate by multiplying it upwards by a factor that accounted for the fact that these patients were on aspirin. It's a challenge that I think is going to be unavoidable when you do this kind of research, and it's something that I've had to struggle with in trying to design this study. But these are essentially not real rates. And then the third thing is that these were derived from cohorts of atrial fibrillation when the patients were diagnosed before 2005. And cardiology cardiology, family medicine, general medicine has made massive strides in terms of managing cardiovascular risk. And because of this, the risk of all forms of cardiovascular disease, and particularly stroke, have actually declined substantially over the whole population, but it's actually declined quite a bit in patients with atrial fibrillation, whether they're being treated with a blood thinner or not. So the blue curve indicates the declining risk of stroke in patients with atrial fibrillation who are treated with warfarin. But even for patients who are not treated with warfarin, the risk of stroke over the last 30 years has essentially been cut in half. And this likely reflects better control of blood pressure, diabetes, lipids, and perhaps the fact that we're picking up milder forms of atrial fibrillation with a lower burden. But what this all means is that the data that all these decisions were based on from the CHAD score are likely not valid today. And, there have been multiple other practitioners that have tried to estimate what the stroke risk is for these patients who are in the gray zone or in the bubble. But I think the way of thinking based on the CHAD score has been so ingrained in terms of how we approach this is that there have been minimal attempts to try and re-regress the different parameters to kind of understand how the risk factors relate to stroke risk in today's patients. And rather, most studies have essentially just classified patients based on their CHAD score and looked at trying to describe the stroke risk in patients with a CHAD score of 1 or 2. And this is a summary table from the European guidelines, but they essentially illustrate, I think they summarize things pretty well when they say that the event rates are generally low and highly variable. So if you look at some studies, they report an annual stroke risk of less than 0.2% per year. And then you have some studies that report an annual stroke risk as high as 2.8% per year. So very wide variations, and they kind of span that whole range that is clinically relevant and may impact your decision whether this patient should get a blood thinner or not. Now, I think part of this variation relates to the fact that there have been different definitions of what defines a stroke or a thromboembolic event. They've come from different parts of the world. But I think it ultimately comes down to the fact that we treat all the different components of the CHAD score the same, and I really don't think that is the case. Age appears to be a much stronger predictor of stroke. It's also the one thing that you can't modify, right? Or at least we haven't learned how to modify it yet.
What about Back to the Future?
Yeah, eventually we may be able to do that. The other factor is it's 2019, but yet we're treating every one of these risk factors as dichotomous variable, right? So if you get the C whether your heart's beating at 100% strength, whether your heart's beating at about a third of the strength of a normal heart. You get the point for H, hypertension, whether you have a blood pressure of 180, whether you have a blood pressure of 120 that's perfectly controlled. You get the D for diabetes if you have diabetes at 6 months duration and you've gone on to lose 20 pounds of weight and your sugars have been perfectly controlled, or if you're someone who hasn't been able to control their diabetes and is on 5 drugs plus insulin. And I think most importantly, you get a point for age, regardless of whether you're 65 years or whether you're 74 years. So within these different population that's more right skewed is probably going to have a higher stroke risk in terms of right skewed in terms of the age distribution. Will probably have a higher stroke risk than patients that are more less skewed. And then finally, and one of the most important things, at least in terms of my perspective source of bias, is that these have all used traditional time to event analyses that have estimated stroke risk using the complement of the Kaplan-Meier, or that are extrapolated using cost regression methods and haven't really accounted for the risk of dying before someone develops a stroke. And we've shown by modeling ICS data, specifically for the study of atrial fibrillation, that if a patient has any comorbidities, the risk of death after a diagnosis of atrial fibrillation is quite high, much higher than the risk of stroke. And if you don't account for these competing risks, you're going to overestimate the risk of stroke. So here we showed what the risk was for patients who had either COPD, chronic kidney disease, dementia, or cancer. And if we estimated the stroke risk using the Kaplan-Meier curve, we estimated a 5-year risk of about 7.5%. Whereas if we do it using the cumulative incidence function, we're looking at about 4.5%. And if you try and back calculate that to an annual risk per year, just using this and just kind of using different analytic methods will put a patient in a category where they may benefit from a blood thinner or where they won't. So, this didn't come across as well. Basically, so looking at all this, I realized I can't answer the questions that my patients are asking me quite honestly, which is why I kind of decided I wanted to do this, even though this kind of didn't really fit within what my main program of research is. So this doesn't show very well, but basically the objectives were to actually describe the risk of stroke and anticoagulation without anticoagulation in patients who are 65 to 74 and who don't take a blood thinner. And I just really wanted to focus on this because this probably would be the least controversial area for me to wade in as someone who doesn't do AFib research, because there's already equipoise as shown by the different guidelines around the world. I hypothesized that for most people within this age category, the annual stroke rates would be less than the 0.9% threshold for anticoagulation. On the flip side, I want to look at in real life data with the actual risk of bleeding in patients who doctors have chosen to start on blood thinners. And our hypothesis was that it would be higher than the stroke risk in this population. And then finally, I want to look at the association with age. And my hypothesis was that there will be a clinically relevant, not just a statistically significant, but a clinically relevant increase in stroke rates, which would impact treatment decisions as someone goes from being 65 to 74 years. Now, I had to start with 66 years, though, because I was using ICS administrative data. We only have access to ODB coverage after the age of 65 years, and typically we need a year to pass before we can be confident that we've captured someone's drug exposure at baseline. So because of this, I set up a cohort. We've identified everyone who we could pick up with a diagnosis of AFib using an algorithm that was validated by ICES. So either it was documented once in hospital or in the emergency department, or the patient would have been a physician or a combination of physicians would have had to build a diagnostic code 427 4 times within a year. Now, the code 427 is messy because it can be used for multiple types of arrhythmias, which is why the algorithm requires it to occur 4 times in a year. And with that requirement, the overall algorithm, at least when it was validated, has a specificity of 99%, although the sensitivity was quite low at around 70%. So we may have missed some people that don't have AFib, but as you'll see, there's a reasonable expectation that most people in the cohort have atrial fibrillation. We excluded long-term care residents, those who are under 66 years, for the reasons that I mentioned. We excluded patients that had CHA2DS2-VASc risk factors, and we included patients that had valvular disease because those patients tend to have a higher risk of stroke, and as cardiologists, we would want to anticoagulate them, as well as patients who are already on blood thinner as of the index date. Now, we followed this cohort over time to identify the outcome.
So what you're looking at is the Canadian liberal policy of anticoagulating anyone over 65 just because they're over 65 with nothing else in the CHA2DS2-VASc.
Yes.
So that's the question. Does that make sense?
Yeah, because that's the one area where we're different from the rest of the world. So we tried to pick those group of people, and we followed them over time to identify hospitalizations for stroke. If they died before developing a stroke, we start off with patients without anticoagulation, and we had to think about how we're going to deal with the fact that a lot of these patients would start anticoagulation. I wasn't comfortable taking a relative risk estimate from an RCT and kind of doing fancy math to multiply for it, so therefore I stopped following those patients for stroke from the point they developed an anticoagulant. So from the moment they started an anticoagulant, and because these patients can accumulate risk factors as time goes on, we really only followed patients for 1 year from the index date. Now, for the patients that started an anticoagulant within the first 2 months, we kind of identified those patients. So if they started an anticoagulant and were otherwise event-free, we took that group of patients to form what we call the anticoagulated cohort, and we used that cohort to try and understand bleeding risk. Now, you asked me, why did we pick 2 months? Oh, yes, question?
I just have a question about the first line. So,
yeah.
So when I think this can to sound good.
Yes.
So when they say like 0.4 weeks within a year, so when do you consider this the date of incidence? Do we have to wait until the 4 of those happen within a year?
Yeah, so it's something that we spent a lot of time arguing about because if you were to, so we could do one of 2 ways, right? So you could set it up so patient has 4 diagnoses, and then you could set the index date as the date of the first visit for atrial fibrillation. And the concern there is that you introduce an immortal time bias, right? Because someone has to be alive. Someone couldn't have died before they get the 4th or hit the code. Or you may wait until someone has fulfilled the 4 criteria, but then the concern there becomes that we know that a lot of events happen early, and we would be underestimating events. So we chose the first approach because the outcomes that we were interested in that were stroke and bleeding, and those outcomes could have occurred, between the first visit and the 4th visit. Now, if we were and because our primary outcome was not death, we felt that was the lesser of the 2 evils, but there is that immortal time bias that is built into how that definition was made. Okay, so going back to anticoagulated cohort, so we chose 2 months ultimately it was arbitrary, but we thought that we had to, we wanted to pick patients who had started anticoagulation relatively early, so they looked like their, so their baseline characteristics hadn't changed very much. And that was the range of time that we thought was clinically plausible for when, if you saw someone with atrial fibrillation and you didn't have much that you were concerned about, that's when you would start them on blood thinners. But ultimately, it was an arbitrary decision, and it's something that we may get challenged on. All right. So statistical analysis, so we analyzed both cohorts in parallel manners, and the analysis were pretty simple. So we used cumulative incidence function curves to describe the risk of the outcomes over time, stratified analyses by year of age, and use fine-grained regression to try and model the association of age and patients' baseline characteristics with the risk of the outcomes. So start off with about 500,000 AF patients. We're left with about 16,000 patients. Most of the patients that we lost were because this wasn't their first AFib diagnosis. Most of them were either younger. Another group was either were outside the age ranges that we were interested in, and about 15,000 patients had a CHA2DS2-VASc risk factor, and about 4,000 actually were on anticoagulation before getting into our study. So if you look at the proportion of AF patients, of a first AF in Ontario, this group that we're anticoagulating in Canada but nowhere else was about 7% of all AFib patients in Ontario. So what did the cohort look like? So 16,000 patients, the full cohort, and about 4,000 patients started anticoagulation within the first 60 days. The age was relatively similar, but there was a slight, the mean age was slightly older in patients who actually were started on blood thinners. The patients that were started on blood thinners were equally likely to be female, but tended to be healthier on average. So less COPD, chronic kidney disease, dementia, cancer, less likely to use alcohol excessively as documented in prior hospitalizations, but also less likely to bleed, which makes sense because clinicians are going to, use their clinical judgment and be more likely to prescribe a blood thinner to someone who's older and otherwise healthy because they may be more likely to bleed. So what were the absolute event rates? So in the primary cohort, over 16,000 patients, these were the events that for which follow-up was terminated. 183 patients for stroke, 347 for bleeds. A lot of these patients' follow-up was terminated because they died, and this sort of goes back to the importance of accounting for competing risks. And finally, about 4,000 patients, like I said, were anticoagulated within the first 60 days, and another 2,000 patients within the next 10 months. Within the patients who started anticoagulation, a very low number of strokes, 28, about 90 hospitalizations for bleeding, and 143 deaths. So when we model this in over time, this is what they look like. This is what the event rates look like. So the vast majority of people started anticoagulation as the terminating event. Less people died, and a much lower portion of people developed a stroke. So when we blow up the bottom part, and you look at the 1% line, you can see that the overall incidence of stroke over 1 year in patients before they started a blood thinner was less than 1%, using the method that we use. So the overall risk of stroke within the population was kind of just below the thresholds within which, using decision analytic modeling, you would believe that most patients would benefit from being on a blood thinner. And then this was the observed risk of stroke, not predicted, but the observed risk of stroke after stratifying patients by age. Now the number of events were small, which is why the confidence intervals are quite high, but you can sort of see kind of a clear increase in the risk of stroke as patients get older from 66 to 74. So in fact, the risk of stroke in a 74-year-old was almost 3 times the risk of stroke in someone who was 66 years old. And for most patients under the age of 70, the estimated risk of stroke was low enough that they really are not, if you believe these numbers, and we'll talk about the limitations, but if you believe these numbers, that a patient would not be expected to benefit either from a DOAC or from warfarin. So what about the other side of the coin, the bleeding risk? So this is what happened in the patients who were started on a blood thinner. So before we talk about the bleeding, look at the rate of death, and it shows the channeling bias by physicians, but the risk of death in patients that started on blood thinners was lower. Most of these deaths were actually non-cardiovascular, so suggesting that doctors were picking and choosing But after starting a blood thinner, even in those patients who were carefully chosen, the risk of bleeding was about 2% over the subsequent year. And these are bleeding hospitalizations. So we didn't even count emergency department visits for nosebleeds or things of that nature, because once again, going back to my bias, I thought I value a stroke more than I value bleeding, which is why I thought the thresholds for capturing someone as bleed should be quite high.
Strokes that were caused by bleeding?
So it would have, if it was a stroke, whether it was ischemic or hemorrhagic, we counted it as a stroke because we couldn't know if the hemorrhagic stroke had transformed from a ischemic event.
And then they wouldn't be in the bleeding category?
No, so these are patients, so you wouldn't have gotten into this analysis unless you started a blood thinner while being event-free. So if you started a blood thinner within the first 2 months without having a stroke.
Could you have both a bleed and a stroke?
Well, you wouldn't have fallen because you wouldn't have gotten into this analysis if you developed a stroke in the first one. And we didn't, and I mean, we have data on the risk of stroke that was here, but I just don't think this type of study design is good to make comments about the efficacy of blood thinners because we have RCT data that show us what it does for stroke risk. So we had much less bleeding events here, so only 90 bleeds. So, and when we tried to stratify it by age, we left at a small number of bleeds per age category. So the confidence intervals now are even wider. But if you look through, we see that like age didn't really seem to have a consistent impact on the risk of bleeding, at least within this narrow age range. So the risk of stroke goes up over time, but at least for patients in this age category, the risk of bleeding appears comparable for a 74-year-old compared to a 66-year-old. So when we tried to analyze predictors of stroke in a group of patients who were not on anticoagulation and the risk of bleeding in patients who are on anticoagulation, trying to mimic the thought process that my patients ask me about. The only significant predictor of developing a stroke within this group of patients that was otherwise healthy and don't have advanced risk factors was older age. So for every year of age, the risk of stroke went up by about 13%. There's a non-significant trend towards patients with baseline dementia, which is interesting because there's a whole body of work looking at the relationship between atrial fibrillation and what's called strokes on developing dementia. On the flip side, age was not significantly associated with the risk of developing bleeding after adjusting for baseline risk factors. Having cancer and prior bleeding increased the risk of bleeds after starting a blood thinner, which is not surprising. Well, and there were some non-significant trends, but I think they're relevant to us as clinicians, but having comorbidities that are not captured in the CHA2DS2-VASc score, COPD, chronic kidney disease, and in general, having a great number of comorbidities tended to put you towards a higher risk of bleeding. Interestingly here, and I think it's because we didn't have enough events, we couldn't observe a significant difference in the risk of bleeding based on what type of blood thinner patients started. So, there's a lot of holes that can be poked in this type of study. So we tried to do some sensitivity analysis. So one of them looked at patients who were diagnosed before 2013, because that's sort of when the Canadian guidelines changed and said that everyone over 65 should start a blood thinner. And that's sort of when, coincidentally, DOACs became available and were covered on the Ontario Drug Benefit. So and we saw that there were no differences in risk estimates, like they were essentially within the margin of error. The second thing that we did was we excluded the patients who were only diagnosed outside a hospital because of the concern about the immortal plan bias, but also because because of the concern about the specificity of the 427 code. And we found there was a sicker population. They died more. They started blood thinners more frequently, but they also had a slightly higher stroke risk. But even then, the younger half still had a stroke risk with off anticoagulation that was less than 0.9%. And then finally, there was the concern about, well, we looked at hospitalizations for stroke. What if someone had a stroke and died at home before coming into the hospital? So we tried to we took those deaths and we broke them down based on cause of death. We found that only 0.1% of the deaths were attributable to cerebrovascular disease. More than half the deaths were due to non-cardiovascular causes. Surprisingly, a lot of them were due to cancer in this demographic. So lots of limitations. Some of the more obvious ones are residual confounding, which we clearly see based on the differences between patients who started blood thinners and those who didn't. A lot of limitations with the administrative data. So sensitivity for stroke detection is only 82%. So this could push us to underestimate stroke risk. Now, so the specificity of the AFib algorithm was 99%, but we're applying it to the full population, and the prevalence of AFib in this 66 to 74-year-old age group is really only 2 to 3%, right? So the positive predictive value, even with such high specificity, was only 85% when tested in patients over the age of 65 years. Some of this atrial fibrillation may be transient, and although classical teaching tells us that all AFib is the same, more recent data suggests that lower versions of AFib may have a lower risk of stroke. So all those things would have caused us to bias our stroke estimates downward. On the other hand, our methods for trying to pick up hypertension, diabetes, and heart failure are more specific than they are sensitive, although there are limitations in both ways. But this means some patients could have gotten into our study while still having CHA2DS2-VASc risk factors, which would bias our stroke risk estimates upward. That being said, although these are all things that may influence the absolute risk of stroke, and I can't really kind of honestly say whether I think I over or underestimated the risk of stroke, I think the most important thing, and the fact that the risk changes over time with age, is less likely to be systematically affected by these sources of bias. At least that's what I believe. So with these limitations in mind, I think the conclusions were that the overall risk of stroke in this group of healthy 74-year-old atrial fibrillation patients was low overall and falls below, I guess, traditional thresholds that people would argue should trigger starting anticoagulation. The risk of hospitalization for bleeding, even when we look at patients who have been selected by the physicians to sell blood thinners, was more than double the stroke risk. I think the most important observation here is that stroke risk increases with age, whereas the risk of bleeding within this narrow age category doesn't appear to change as much. But the bleeding risk within these group of patients appears to increase by the presence of non-cardiovascular comorbidities that are not captured within the CHA2DS2-VASc score. So what are the implications? I think first and foremost, buyer beware. This is not my area of expertise. And also, there's a lot of limitations with the data. So we need to see this replicated elsewhere. I definitely wouldn't want to use it to change practice just yet. But if it is true, then it suggests that what we're doing here in Canada may be unnecessarily aggressive, particularly for patients who are in the younger, at the younger end of the 66, 65, 75 age bracket, because we're less likely to provide net clinical benefit. And it's also unlikely to be cost effective either. And these are medications that are paid for by the ODB. There should be increasing motivation to anticoagulate with age, though, particularly if patients are healthy. And particularly if you can offer your patient a DOAC. So if you're in some of the provinces in Canada where accessing a DOAC is difficult, or if a patient has chronic kidney disease and you cannot prescribe a DOAC, then perhaps we should wait until the patient's stroke risk is clearly higher. Just the data in CHEST guidelines maybe are too aggressive, and perhaps maybe the American guidelines are perhaps too lenient. Maybe should consider, and maybe patients can benefit from anticoagulation before they hit the 75-year range. And particularly, I think the European and the NICE guidelines may sort of struck the right balance, but I think in their guidance to consider which patients to anticoagulate, I think there should be a clear emphasis on higher consideration as these patients get older. So because it's not my area of expertise, I probably would have gotten laughed at if I applied for peer-reviewed funding to try and ask for this. So this was funded by the generosity of the U of T Polo Chair for Young Investigators, which kicked in $10,000. And then I kind of had a chat with Dennis Crow, and I spoke to him about this idea. So he essentially was kind enough to just give me money from his foundation grant to do this research. So very grateful to him for doing that too. All right, and thank you for your attention. Alan?
Well, that was very provocative. You really have two papers here. The first paper is to point out the softness of the sand on which the recommendations for widespread anticoagulation in the population, because atrial fibrillation is very common in the age 65 to 75, and that I'm a bit shocked to know that the CHA2DS2-VASc score comes from data that had only 25 events. Has it never been replicated in other populations?
So it has been, but like I said, people have always approached it by reclassifying people into CHA2DS2-VASc scores.
So nobody took a new population and asked whether the CHA2DS2-VASc thing worked in a much larger event.
So they have, but they have by taking a new population, classifying patients based on CHA2DS2-VASc.
Yeah, but nobody took a fresh population and tried to validate that on a larger data set.
So they have by kind of re-regressing and showing that they related to stroke risk, but no one has sort of gone, to my knowledge, I don't think anyone has sort of gone back and tried to regress, look at the coefficients and try to see, well, do the coefficients
Stay stable, yeah.
stay
Okay, so
stable, and do they relate to, and are they equal, right?
So that's one. You mean the equal interval? Yeah.
Right.
That's one shocking thing. The second shocking thing is that this is based on a decision analysis where the thresholds cut off at like 0.9% and 1% and 2%. As a reformed, recovering decision analyst, I used to do a lot of decision analysis. I would never have the confidence to say that guidelines should come from thresholds in the sensitivity analysis that are that close together. I know what it takes to make a model to extrapolate, and there's tons and tons and tons and tons and tons of opportunity for bias because there's tons of assumptions that have to be made in these models. So models should be used to kind of guide ask what the important questions are, but translating them into firm thresholds by taking a risk score like CHADS-VAT2 based on such little data, and that's just shocking. And that in itself is worthy of paper. Number two,
can I just make a comment about that?
Yeah.
So I think you're absolutely right, but can you just bring up that original figure
the
from Mark?
Figure.
So
I doubt that he would stand behind that.
I think he would, and like we've modeled this too and have come to the same kind of conclusion. But the point is not which is the preferred strategy. The point is the smallness of the absolute difference at that end.
Yes.
That's the point. I mean, if you look out over at the annual rate of stroke at 10%, there's an enormous difference between the different strategies. And as you get into lower and lower, it doesn't really matter which is the preferred one. The critical thing is that the absolute difference between any of the strategies is small. And what that tells you is that A, it's highly uncertain, as Alan says, and B, that this is a preference-sensitive decision. That people's preferences of taking anticoagulation, their preferences of avoiding stroke are critical in making that decision. It's not just about specifying the absolute event rate, it's taking their judgments about how important these things are relative to each other on board and making treatment.
So that was going to be my third point, which is that since this is based on qualities, the Q in qualities, I mean, pay me enough money and I can make that Q look like anything. So I completely agree with that. And then here's my fourth point. This is a huge industry.
Yeah.
There's a lot of money behind this. So your conflicts of interest, I'm going to go through those with you after. Your conflicts of financial conflicts of interest, but I can tell you that this would be like pissing into the wind, sending this into a journal and letting the completely dominated by industry group of scientists, including those that we know who are good people, but they are completely conflicted. There's an enormous financial interest in keeping this going. And then when you go to send this into a journal, you need to alert the editors to that and ask them to only pick reviewers who do not have financial conflicts of interest with industry. And they're going to say, well, those are the experts in the field. So you should not be defensive about the fact that somebody outside the field of anticoagulation or atrial fibrillation is asking the question. That is a strength of you doing this, not a weakness of you doing this. And I would carefully craft the cover letter to say, a lot of people that aren't going to like this answer, you have to find people who aren't biased by financial interest, because it is huge in this.
Okay, thank you. Yeah.
I'm surprised you didn't even so much as mention NNTs and NNHs for treatment and the harm. I mean, obviously it's not hard to get there from the, as you rightly emphasized, the absolute difference and so on. But I have always found and preached that dealing with, in the clinic, dealing with the NNTs and no need to treat, no need to harm, is a very powerful way of helping patients to make decisions, which is relatively recently that we've even given them the choice of making decisions, as you know. You didn't even mention it. I mean, when you're talking about numbers needed to treat, which range from 100 even to 1,000 in one example you gave, and then you have the number needed to harm in the range of about half that. That's a powerful message. I mean, people are much more used to making decisions based on likelihood of events than we give them credit for.
I mean, you're right, and I thought about that, but I think my reluctance to do that just comes from our respect for the limitations of using observational data to comment on the efficacy and risk of treatments when you're trying to study something and the clinicians are prescribing the medication for that purpose. So if a clinician is prescribing a medication thinking about the risk of stroke and the risk of bleeding, I do think there's a lot of challenge bias. So let's say, for example, it turns out that these blood thinners cause hip fractures, and that was something that clinicians are completely unaware of. I feel like that would be the kind of study in which I would have felt comfortable commenting on numbers needed to harm, but I think just because of because of the challenge bias, I don't think this is the right type of study to do that. I'm not
You
sure
don't want to
what
extrapolate the effectiveness rate onto your lower baseline rates to say that the NNT blows up.
Well,
Because you could
so
do that.
part of my reluctance to do that is also I would wonder if, as a clinician, someone looked at a patient and said, well, you've had like 5 seconds, you've had 5 minutes of AFib, and your blood pressure now is very well controlled, and maybe that's why I am choosing not to use the blood thinner in your case. And I think that's where my reluctance comes from. And then I think, I don't know, I mean, maybe I'm naive, but I would hope that I can just sort of present data and then people could can think about that for themselves. That's Dr. Campbell.
So that was a great presentation and a really important study. For the stroke, did you only look at hospitalizations or did you look at emergency department visits?
One looked at hospitalization. Then we thought about, should we try and capture? So, and the reason we did that is, we just thought it was unlikely that someone would have a clinically relevant stroke and be sent home from the emerge. And we thought about looking at TIAs, but then TIAs are so, are so subjective, particularly once they get sent home from the emergency department, that I just thought that I would rather pick something, that was slightly more specific, recognizing that we may be undercounting. But I thought if I describe the hospitalization for stroke in Canada, that should carry similar meaning, whether we're talking about this in Denmark or Germany or Alabama. But I thought it'd be, I thought a discharge from the ED with TIA may be interpreted differently in different places.
Yeah, no, fair enough. It probably will account for underestimates of stroke. I think about 15% of minor strokes are sent home in Ontario.
Okay. Okay, so strokes with a clear neurologic.
Yeah, even not even including TAs, of which about 50% are sent home.
Okay. Okay, so maybe I should think about that. Now, I was in doing this and also trying to write the paper, I'm always pretty explicit at saying that this is a hospitalization for stroke, but that should be something.
So I think it's a good decision, but you probably need to explain that you will mix up.
Okay. Yes.
Being a stroke neurologist, I have to have a lot of these conversations, and what I find hard is not to compare percentages or numbers to treat to next to each other, because what you said in the beginning, you count on ischemic stroke having more impact than bleeding. So was there any way to see what the impact was on health from the strokes versus the bleeding, like not to compare just numbers?
No, so I didn't do it here. Now I know other people, I think you've done some of this, right? But people have looked at the, through a stroke registry, looked at the patient's outcomes afterwards and tried to extrapolate based on where they were discharged, whether they were discharged home, whether they went to a long-term care residence. I haven't explored that issue here. I know clinically speaking, and you can correct me if I'm wrong, but embolic strokes from the heart, particularly setting of AFib, tend to block off large vascular territories and tend to leave patients with much larger deficits than small vessel strokes. So I would imagine that these strokes are even worse than the typical strokes, but I'm not sure what you think.
Yeah, but intracerebral hemorrhages, when you're on anticoagulation, have a higher impact on health and death.
Yeah, so for what it's worth, I mean, we looked at the numbers, and the absolute numbers of intracerebral hemorrhages were very low, and I think that becomes even less of a consideration when you think about the newer blood thinners, because the DOACs seem to not cross the blood-brain barrier as much. So interestingly, they drop bleeding substantially, but the risk of GI bleed tends to be slightly higher with DOACs. So the risk of intracranial bleeds are much lower. So I would imagine that most to move towards more DOAC, most of the intracranial bleeds, when they do happen, are more likely to occur from an ischemic that transforms than a primary hemorrhagic stroke. But you're right. Sure.
Just for the translation into clinical practice of these numbers.
Well, I mean, I again would like to reiterate the point I made before, which is that it's evaluation of the importance of these outcomes to patients, and not just in a general sense, like measuring utility of a bunch of people. It's like individual people saying, like, what does a stroke mean to you? How, and for someone who's a pianist or a surgeon, like, avoiding a stroke is a big deal. Whereas, you know, for someone who doesn't have that kind of reliance on manual dexterity, it may not be as important. And there are lots of papers about some of which I have contributed to, about the importance of including preferences in clinical practice guidelines. And this is the example that lots of people commonly cite. But if you read the atrial fibrillation literature, there isn't really much of that there. It's all, like, it's about the numbers. You know, what is the absolute event rate and what is the absolute bleeding rate? And there isn't as much effort on trying to quantify the importance of those things and to try to bring those factors into individual decision making. Because I think if you look at this, like, the differences, you can argue about which is preferable, but the differences are very, very small at low stroke risk.
Yeah, you're right. And that's what I made a point to kind of talk about where my own biases lie, where prescribing a medication to someone who's otherwise healthy and how much I value a stroke versus bleeding, because they do matter. That being said,
it's what they value.
Yeah.
It doesn't matter about your bias.
Yeah, yeah.
It's like their interpretation of the data and what's optimal for them.
Right. But my bias is sort of interpret how I read the literature and perhaps how I design the study and some of the assumptions I make. That being said, if it were me, even at a 0.5, even a 1 in 200 chance of a stroke per year, I'd rather take a blood thinner. But not everyone else may feel the same. And where I think it becomes, like, particularly a disservice to patients are, you know, patients who maybe have a higher bleeding risk or are coming up for a procedure, and we kind of keep them on the blood thinner until like 2 days before the procedure, and then they bleed, or we start it too soon afterwards because of this guideline that says you need to start a blood thinner, you know, for something that has a 1 in 200 chance of happening.
The other thing is, over time, people sort of walk down this.
Right.
They walk across the x-axis here as they get older and they acquire comorbidities. And if you lose the opportunity to start them on something relatively early on, you know, a lot of people with atrial fibrillation are not treated.
Yeah.
And if you miss that opportunity to treat them when they're first diagnosed, you may permanently miss that opportunity.
It's also worth knowing bleeding risks that, you know, are higher when you first start the oral anticoagulants and then decline over time. And so you're catching people at their highest bleeding risk time.
Right. Right. That's a good point. Yeah. Sorry, you had a question.
Did you look at sort of in the months data that you had, did you look at changes in practice between DOAC and warfarin, like as you were, it's a sort of a transition period of physician behavior of picking one over the other. Did you see anything with respect to time in the work that you did?
No, I mean, we didn't look. I would expect that now almost everyone is starting on DOAC, but we haven't looked at that specifically.
Okay.
Okay, thank you so much for coming around. Great rounds. Okay, and we're on again. Actually, I don't know when we're on again, but watch your email for our next round.
Thank you.
Thank you. Yeah, sure.
Very interesting. Thank you.
Are you partially in clinical work or 100%
No, I do like 30% of my time in clinical.
Good.